So if you're not accustomed to working with pediatric patients, you might struggle through growth and development. There's so much to remember. My job today is to point out the most important things to make this easy to remember for you, and especially if you're someone who works with adult patients. So, where do we start? The first thing to do is to make sure that you use the correct terms when you're taking care of these little itty-bitty patients. So, what do you call them? Well, if they're born before 37 weeks, the term that we use to describe that baby is a premature infant. And certainly you've heard the term preemies. That's what we're referring to. A newborn is going to be a baby that's born after 37 weeks up until about 28 days. The first part of our assessment this morning is going to focus on the newborn. The infant and toddler and preschooler, school age and adolescent people are ones that we'll talk about a little bit later in our video. So let's focus on the newborn exam and newborn growth and development. It turns out that when we start, there's 6 or 7 aspects of a newborn's development that we pay really close attention to. And we're going to look for the same 6 or 7 things until they're a year old. We always look for progression and maturation as they get older, and that's why it's important to know where they start. All of these 6 or 7 aspects are pretty self-explanatory, but the third one, personal social, may be a little ambiguous. Personal social refers to the baby's interaction with humans in their environment as well as interaction with their environment. So again, they're pretty self-explanatory as our first 6 or 7. So the first one that we're going to focus on with the newborn is gross and fine motor skills. To be perfectly honest, a newborn has virtually no fine motor skills, none to speak of. But with gross motor skills, this is what we expect of a normally developed newborn. We expect a newborn to be able to lift their head and to have equal movements in all 4 extremities. So I have a question for you. A full-term newborn infant has asymmetrical movement of his left upper extremity, and there's clavicular crepitus. Here's my question for you. What might have contributed to this? Well, why does a baby have clavicular crepitus? It sounds to me like a broken clavicle, and it is. So why does a baby have a broken clavicle? I don't think it's because somebody dropped him. It's probably because the baby was very big. And the term we use to describe a big baby, a big newborn, is macrosomia. The word macro means what? Big. Somia means what? Body. So it's a big body. It had difficulty getting out into this world. So the best answer for question number 1 is number 1. Well, the next aspect of the newborn exam that we want to look at is personal social. Remember what I said that was. It's the interaction of the newborn with his environment or with the humans in his environment. With a newborn, our expectation is that they're going to look at another's face. The reason for that is because your eyes, human eyes, are very bright and shiny, and they ought to attract the attention of a newborn's eyes. So that's our expectation with regard to personal social. The next aspect of a newborn exam is language. Now, you know as well as I do that newborns don't talk. Their sole communication tool is their cry. That's a newborn's communication skill. They cry when they're hungry, they cry when they're cold, they cry when they're in pain. That's the sole means that they have to communicate with you. I mentioned that they cry when they're cold, and I want you to remember that the newborn has difficulty, especially in the first day of life. The newborn has a lot of difficulty with managing and maintaining their own body temperature. And the reason for that is because they've got an immature thermoregulatory system. And because of that, the infant might cry simply because he is cold. Now that you've heard the cry of adults and children, you can easily distinguish a cry that's pain or a cry that's sadness. But with infants, the most important aspect of listening to their cry is the pitch. The pitch of a newborn's cry can tell you a lot. And one of the things that it might indicate is neurologic disorders. And in fact, I've got a question for you. Here it is. It's important to assess reflexes in a newborn. Why? Why is it so important to assess their reflexes? Well, I want you to look at number one, and I'm going to jump to the right answer. It's because when we assess reflexes in an infant, it lets us know about the maturity of their neurologic system. So here's what I want you to think about. If I wanted to assess you neurologically, I would probably ask you your name. I'd ask you how you got here today. I'd ask you where you went to graduate school. And based on your responses, I'd have a really good idea about whether or not you were neurologically intact. Well, we can't do that with an infant. Our best and most effective way to assess them neurologically is to assess their reflexes, and that's why we use them. So take a look at the newborn reflexes. These all should be present at birth. I call these the lucky 13. These 13 reflexes better be present when an infant is born or a newborn is born. If they're not, it's the unlucky 13. So they all appear at birth. I want you to look at them. And they begin to disappear at various times with the exception of my last bullet. I want you to look. It's a blink reflex. We never lose that. The gag or cough reflex, and you can look at the others, but those never go away. So let's look at a few of these newborn reflexes. Here's the first one, and we're going to play a game. The game is called Name That Reflex. I'm going to describe it to you, and then I want you to think about what it is if you don't recognize it from the image. The first reflex refers to hyperextension of the head, abduction of the arms and legs in response to sound, and typically it's a loud sound. This reflex appears at birth, and it usually disappears around 3 to 6 months of age. The other time it might reappear is during a horror movie. Okay, that was a joke. All right, so you get my point. The name of that reflex is the startle reflex, and another name for it, as I'm sure you know, is the Moro reflex. Here's another one for you. Look at this baby. It's obviously not a newborn. It's a little bit older. This infant's head is turned to one side. Look at it. The corresponding arm extends and the opposite arm flexes. Well, if you look at that image, I think you'll think that looks like a fencer. And in fact, that's exactly what we call this. It's a fencing reflex or the tonic neck. And so those are common reflexes, and that's one that you ought to be able to describe. So it, again, is present at birth and disappears somewhere around 4 to 6 months of age. Here's your next reflex, and it's one of my favorites. It's one of my favorites, and this is what happens. This is obviously a newborn. One of your biggest clues that this is a newborn baby is that he's not able to hold and control his head upright. So the examiner has this newborn right under the armpits, and it's also got his feet flat on the surface that is in front of him. When you do that with a newborn, he's going to begin to step or take steps forward. That's called the stepping or placing reflex, and it's really kind of cool. They're born with it, obviously, and then it disappears right at about 2 months of age. But once again, it's another indication that the neurologic system of this newborn is intact. Look at this reflex, and it'll be one of our last ones. This one, the examiner has his finger right on the sole of the foot. When the examiner does that, the toes fan out in response to a stroke on the lateral sole of the foot. So this is called the plantar reflex. Another name is the Babinski, and that might be the one that you've heard of. The toes will fan out anytime there's that stroke on the lateral sole of the foot. If that were in the hand, we would call it the palmar grasp. So this one usually disappears somewhere around 1 to 2 years of age, and you might have observed this before, not necessarily in a newborn, but if your background is of adult patients, you might have observed a Babinski reflex in an adult with a severe closed head injury, or maybe an adult who's had a bad stroke. When you find a Babinski in an adult, it's always a poor prognostic sign. But in a newborn, it's very, very encouraging to us that that newborn neurologically is very healthy. So let's take a look at how you do the Babinski reflex. I want you to look at the sole of the foot, and you can see the direction of the arrow. Because when you use a reflex hammer, the other end of the hammer typically is in the shape of a spoon, and that's what you'll use to elicit the Babinski. So if you look at image A, that's the direction that you'll use when you assess the Babinski. And if you look at image C, what you'll find is a fanning of the toes. Once again, normal in a newborn. Image B refers to what we usually find in an adult. Well, it's time for another question, and here it is. In a normally developed term infant, which fontanelle is normally open at birth? Well, I'm going to jump to the right answer, and I want you to look at number 4, because with infants or newborns, the anterior fontanelle must be open at birth. Sometimes the posterior fontanelle is open. So here's your image of the top of the cranium of an infant or a newborn. The big anterior fontanelle is about the size of your thumbnail. It's the one that better be open at birth, and it generally closes sometime after 9 months. But I also want you to focus on the posterior fontanelle. If it's open, and it might not be, if it's open, it's going to be very, very small, and it closes early. Now, why do we have fontanelles? It's hypothesized that the soft tissue, meaning the brain, grows very, very rapidly at this time of life for the infant or the newborn. The bones, which are hard tissue, can't grow as rapidly. Consequently, the fontanelles serve a great purpose to allow brain to grow at an adequate rate. So here's another question for you. At birth, the neonate's head is usually, like, how big is it? Well, it's usually 1 to 2 centimeters larger than the infant's chest circumference. That's why when you look at a newborn, the head always seems to be so big. But it's also about the only time in your life when your head is bigger than your butt. So neonates have very, very big heads, and that's why number 1 is the best answer. Well, since we're talking about the head, there are 2 common times or 2 common scalp and skull things that we need to talk about. They deserve particular mention. The first one is a condition called caput succedaneum. Caput succedaneum is an edema or a swelling, sometimes as visible bruising, over the presenting part of the newborn's head. It's completely benign. It resolves in a few days, but it's very, very disheartening for a new parent or a caregiver to look at the head and see what looks like bruising. So do some good teaching, but mostly do reassurance with them that this condition called caput succedaneum is completely benign. Why do they have it? Well, they usually have it, and as you examine it, you'll be able to palpate a lump or even a bump over the head shortly after delivery. As I said, it's totally harmless, but it usually is from prolonged pressure on a dilated cervix or prolonged pressure with vaginal walls of the baby's head, and that's what produces a swelling and puffiness that you'll observe. The second condition that deserves mention with regard to the skull is something called cephalohematoma. This one's not as common as caput succedaneum, but again, it deserves mention. With cephalohematoma, I want you to take a look at the image. It's a collection of blood between the baby's scalp and the skull. This one is not going to go away in a few days. This usually takes a few weeks. So again, you'll have to do this with a caregiver. You'll have to do some good teaching because it's scary to look at that on your newborn infant. So why do they get it? A cephalohematoma is usually described as a minor injury unless it's your baby. But it's a minor injury and it occurs during labor and delivery. Generally, if the infant's head is larger than the mother's pelvic area, there's prolonged pressure, and cephalohematoma is more likely. Well, you can also see a cephalohematoma with birth assisting devices like forceps or even a vacuum, it just makes this injury much more likely. So again, cephalohematoma is one of those two skull conditions that you'll observe. Well, while we're talking about the head, we have to talk about head circumference. And here's a couple of important things for you to note. The image on the top is obviously not a newborn, but it's to remind you that head circumference is so darn important that we measure it until that baby is 3 years of age. When we measure it in a newborn, we always measure it at the largest circumference above the ears. And it's important to plot it, and we'll talk some more about that in a minute. But here's another question for you. A 1-week-old infant, the name we still use is newborn, does not have a red reflex in his right eye. So my question is, what should that indicate to you? Well, if you look at the answer choices, you may have conjured up at least a couple of things to think of with an absent red reflex. But the best answer here is obviously congenital cataracts. So let's look at what a red reflex is and should be. A red reflex should always, 100% of the time, without exception, be present bilaterally at birth. In fact, it is never normal to not find a bilateral red reflex. If you don't find one in a newborn, there are two conditions that ought to come to mind first. The most common is probably congenital cataracts, and that is a strong familial component. The other condition that's associated with an absent red reflex, and it doesn't necessarily have to be bilateral, is retinoblastoma. Retinoblastoma, as you might remember, is a tumor of the retina of the eye. It's not very common, but it's a common tumor in it's a common tumor in newborns and in very young children. So what about the newborn's vision? Like, how well do they see? Well, it turns out their vision is terrible. If they could look at letters on an eye chart, the best that a newborn could see is the E on the top of the chart. That's about 2200, and that's the best that a newborn's vision is. It's estimated, because this is really hard to determine, that a newborn's vision is anywhere between 2200 and 2400, which honestly is terrible. Let's go back to the red reflex, because that's the important point. I want you to look at these images. There are 3 of them. The top image is a normal finding. It's what you ought to see every time you assess for a red reflex. And when you look at the image, you can see the bilateral red reflex is present. That's how you should always find red reflexes in any newborn and any live human being. I want you to now look at the middle image. It indicates a loss of that red reflex, and I put it in here because a lot of you have not had a chance to see that. If you look at the right eye of this, obviously not a newborn, you can see that there's not only not a red reflex, but it also looks like there's a white reflex. A white reflex is called leukocoria, and that always is an abnormal finding. The third image, the one on the bottom, indicates a loss of a red reflex and a really good white reflex there for you. And again, the word that we use to describe a white reflex is the term leukocoria. So, not a newborn, but again, those are good examples for you for present and absent red reflexes.